Hello guys, so welcome back again to the next Farre series of orthopedics. Right, so yesterday was a little rough day for us, so there were a lot of technical glitches in between, so we could not complete the trauma. So now today we are going to complete the trauma as well. Okay, so yesterday I have stopped the class at supracondylar fracture humerus, right? So today we are going to discuss the lateral condylar fracture. I remember that yesterday I've told a little bit of lateral condylar fracture, but it was in a hurry. So today I'll tell you in detail. Good evening, Arya Kumar. So let us now start the class quickly, and today we are going to finish it by time. By 8 we are going to finish the class, okay? So let's start. Okay, the first question today we are going to discuss is about the lateral condylar fracture. Hi MBBS 8981. Can you tell me what is your name? So lateral condylar fracture, as we have discussed yesterday, this is also a type of pediatric fracture. So this is also very common in pediatric fracture, but this is also seen in adults also as well. Okay. And then what is the most important thing about lateral condylar fracture? What you have to remember. So this lateral condylar fracture, you remember this is in the humerus what we are talking about. Okay, don't get confused with the femur. Okay, Mahesh. So now this condylar fracture of humerus is very common in pediatrics, as I've mentioned, and this is also seen in adults. But what is most important thing, what you have to remember is this is an intra-articular fracture. This is an intra-articular fracture that you have to remember. And what you have to remember is the mechanism of the injury. So the mechanism of the injury in this particular fracture is the varus. So this point you have to write and remember. So there is a varus force which acts on the elbow, and this varus force will result in this lateral condylar fracture. So whenever there is a varus, okay, hi from Mysore. Okay, Mahesh. Yes, BMS. Sure, but we are not very sure about the topics because we are from the modern medicine, right? So that is the mechanism of the injury. So what we have decided, we are going to write the definition, what is a lateral condylar fracture, right? And then we are going to write the pathoanatomy. So what is the pathoanatomy of this particular lateral condylar fracture? So now if you see, this is a fracture of the distal humerus, right? So this is a fracture of the distal humerus, and we know that distal humerus is nothing but you can just draw a square of equal width. So this is the square of the equal width. So that will become the distal humerus. So that will become the distal humerus. Right, and now in the distal humerus part we are discussing about the intercondylar fracture, intercondylar fracture or the lateral condyle fracture. So why I'm specifically telling it is lateral condyle, because we have the medial condyle as well. So we have the medial condyle fractures also as well, right? 1 second. So now I have told you the mechanism of the injury, and now the patient complains, right? So the complaints, the signs and symptoms. So what the patient complains about, again, there would be a swelling and the pain in the elbow, right? Pain and swelling in the elbow. And if you ask about the, good evening, Sabyasachi. So now if you ask about what is the mechanism of the injury, they would tell that there is some varus force which has been applied to the elbow. So maybe slip and fall or fall from a bicycle, right? If you ask in detail, they will tell the mechanism of the injury, right? And now what are you concerned about? What are we concerned about? So it is a lateral condylar fracture, because you know that this is again an intra-articular fracture. You're mostly concerned about what? You're mostly concerned about the X-ray to see what type of classification this is, what type of classification this belongs to. So for that, you have to understand the pathoanatomy as I told you. So now let us understand this. So this is a lateral condylar fracture. So now this is the lateral condylar fracture, and these are the parts of the distal humerus. So this is your capitulum and this is your trochlea. This is the capitulum and this is the trochlea. And here the classification system was given by Milch. And there is one more fellow you have to remember, that is Jacob, Milch and Jacob. These are the two fellows. Yes, that is the definition of the lateral condyle. So these two, Milch and Jacob, has given us the classification, but what you have to remember at your level is the Milch classification. So the Milch classification is for your lateral condylar fracture. Now tell me, what is the classification name for supracondylar fracture humerus? Yesterday we have learned. So what is the name of the supracondylar fracture humerus? So now you type the answer and I'll continue explaining the Milch classification. So the Milch classification here is of two types. So this is called the type 1 classification and this is type 2 of Milch. So what is the basic anatomy which you have to remember here? So what you have to remember is this. The capitulotrochlear sulcus. So you have capitulum, you have trochlea, and the gap between them is called the capitulotrochlear sulcus. And if you see the difference between type 1, so I've told you this is 1 and this is 2, right? And if you see what is the difference between type 1 and type 2, now if you see the fracture which is there here in the lateral condylar, it extends into the capitulum and it is only up to the sulcus. That means it is involving the capitulotrochlear sulcus only, right, in type 1. But when you come to type 2, the lateral condylar fracture here, the fracture is involving complete capitulum and it is also taking a part of the trochlea. So at the apex of the trochlea is the fracture. Till the apex of the trochlea is the fracture, right? You get that point? So this is very, very important, and whenever there ask you the classification, so if you write this particular point, you're going to get more marks, right? Yes, very good, Mahesh. It's Gartland classification for supracondylar fracture humerus, and for lateral condyle it is Milch, right? So Milch, there are two types, type 1 and type 2, and here usually what they tell you, yes, extension type is also very common, that is type. Types of supracondylar fracture are flexion type and extension type, but the classification name is your Gartland's classifications. Here the classification name is your Milch classification, okay? And there is one more classification for lateral condylar fracture just to assess the fragment. So this lateral condylar fragment, if you see, this is mildly displaced, right? So this is an incomplete fracture. You can see the fracture is not extending complete. It is not complete till here. It is only up to here. And now what you have to remember is this lateral condylar, whatever the lateral condyle part is there, this is a CEO. That means what is a CEO? Common extensor origin. So all the extensors of the forearm are attached to this lateral condyle. So here in the type 1, what happens? The fracture is not complete. And here the fracture is complete, but it is displaced, it is undisplaced or mildly displaced. In type 3, because of this pull, the fracture fragment is completely displaced, right? So it is an incomplete fracture, complete fracture, and then this is your completely displaced. So yesterday we have learned so much about the displacement, so this is about your displaced fracture, right? So this is incomplete fracture, yet this is a complete fracture. This is a normal classification for the lateral condyle, right? Radha, good evening. But what is most important, guys? You're going to write about the Milch. You're going to write about the Milch classification, and what is the important thing we have to remember? The capitulotrochlear sulcus, and if it is only up to the sulcus, it is type 1, and if it is involving the trochlea, it is type 2. Now tell me, are you aware of the Salter-Harris classification? Guys, are you aware of the Salter-Harris classification? So whenever we are discussing about the pediatric fractures, so this could be a potential MCQs for your exams. So can somebody name what is the Salter-Harris classification? At least tell me for what it is used. For what is this used, the Salter-Harris classification? So the Salter-Harris classification is mainly used for the physis. Whenever there is an injury of the physis, we use this Salter-Harris classification. And now, not to break your heads, just remember Om Pathak, you can get all the notes of this lecture in the link which is provided below, or in our Telegram channel, or in the app as well. Okay, and yesterday's notes is still not uploaded in the app or in the link because we have not completed the trauma chapter yet, and we are going to complete it today, and by today night you are going to get the notes of the trauma. Okay, is what are you little confused about, Arya Kumar? Yes, the growth plate or the physis. Yes, the growth plate is also called the physis. Yes, bro, it is that the growth plate, the physis. So whenever there is an injury which is involving the physis or the growth plate, we use this Salter-Harris classification, right? So we use the Salter-Harris classification, and here you have to understand that this Salter-Harris classification is again remembered as a mnemonic, right? SALTE and R, right? And you also know that where is this physis present. So if you take this as your bone, so the part which is here, this part is called the epiphysis, right? And now this is your metaphysis, this part is your metaphysis, and there is a slight, this part between the epi and the metaphysis is the growth plate, right? So this is the growth plate. And now what are the various fractures which can occur in this? So the first one which can occur here is, that is through the growth plate. So it is a straight fracture through the physis itself. So through the physis itself. For S is for straight. So through the growth plate, right? And then A is for above. So A is for above. Above, what is above the physis? Here, what is above the physis? Which means it is the metaphysis, right? Yes, very good, Mahesh. Through. And S is straight. And A is above the physis. And then so next is L, which is lower, and this includes, the lower one includes the epiphysis. So what is below the growth plate? It is the epiphysis. So here if you see, if the fracture is only through this part, only through the growth plate, that means it is Salter-Harris type 1, right? So now we know this is type 1, type 2, type 3, type 4, and this together is a crush injury which is type 5. Okay, and T stands for through. Through matlab, what is the meaning of through? It indicates the, through matlab, it indicates metaphysis, growth plate, that is physis, and epiphysis. So all the three which are included like this. So the fracture passes from the meta through the growth plate to the epi. So this is through, right? And then we have the final one which is called the crush injury. So the crush injury is not usually seen on the x-ray. It is usually the outcome once there is a growth disturbance which is happening in the limb, and then the retrospectively if we see the x-rays, then we decide that this is a crush injury which is not easily diagnosed on the x-ray, and you have to be very cautious and very suspicious, right? And explain the patient. Yeah, because these are usually crush are missed, or they are not seen on the x-ray. They are not seen on the x-ray because the complete physis, it is crushed, because physis is lot of cartilage. You cannot see it on the x-rays, right? So it is not involving either the metaphysis or the epiphysis, only the physis which is completely crushed. That is why. Fourth one is through. See, fourth one, if you see the fourth one, the fracture is like this. So from the meta, okay, sorry, let me take this one. So it is from the meta like this. Whereas if you say type 1, if this is your physis, the fracture is exactly through the physis like this, and this can be seen on the x-ray. And here there are certain zones in the growth plate, right? So the weakest zone is zone of hypertrophy. Now you go back and you will go to the anatomy of the growth plate, and then you will see the zone of hypertrophy. So this is the weakest area in the growth plate, and from through this the fracture occurs. And the classical example is your SCFE. So slipped capital femoral epiphysis. So this is SCFE, and this is usually seen on the X-ray. So that is the difference between type 1 and type 5. Next, Mahesh, in 4 metaphysis, physis, epiphysis, all three. Yes. In one only physis. Yes, correct. So now why I'm telling so much about this physis here, because you have to remember that this particular type 1 is Salter-Harris type 4, right? So Salter-Harris type 4, and this is Salter-Harris type 2. That is why I have taken a brief. That is why I'm teaching you briefly about the growth plate, because this is sometimes asked in the MCQs. So what is type 4 of Salter-Harris, and what is Milch type 2 is, right? So they will ask you this question. So please remember these two diagrams. So if you write these two in the exam, you will get full marks, right? And one more important thing which you shouldn't forget in case of your lateral condylar fracture is the complication. So how do you treat it? So you take the X-ray, and now you decide the lateral condylar classification. So whether it is Milch type 1 or type 2, or whether the fragment is positioned there or not. And that depending upon that, you treat it either conservatively because it is an undisplaced fracture, or you treat it with surgery, fixing it with the K wires. So once you are done with this, what is most important thing is the complications of the lateral condylar fracture, and this is expected by the examiner. So what is the complication? So the first important thing is, what is this? Non-union. So yesterday we have dealt in detail about the fracture healing, right? And I've told you the complications of healing. It could be a delayed union or a non-union or a malunion. In supracondylar fracture humerus, we have discussed that fracture has the tendency to malunite, and that will form into cubitus varus. That is a gunstock deformity. But here, because it is an intra-articular fracture, and any intra-articular fracture, because of the synovial fluid which is present in the joint, and this synovial fluid has various inhibitors which will inhibit the fracture healing. Hence, most of the intra-articular fractures land up in non-union, and one of the classical examples of such a fracture is your lateral condylar fracture humerus. Right? Is that clear? Okay, so this is one of the important complication here. And not to stop with this non-union, what happens is, here there is one more important complications you all should remember, and this is asked in the exam as a theory question or an MCQ. What is your tardy ulnar nerve palsy? So what is your tardy ulnar nerve palsy? So what do you mean by the word tardy? Tardy is, what is the meaning of tardy? Tardy means slow. So slowly your ulnar nerve is paralyzed. So why it is paralyzed? Because of this complication, the non-union. And because of the non-union, what is happening? The lateral condyle has stopped growing, but the medial condyle growth is still maintained, and hence this will land up in a complication, a deformity, which is called as cubitus valgus. So this is called as cubitus valgus. Yes, Salter-Harris is mainly for predicting the growth disturbances. What do you mean by accurately? So it will tell you whether this particular patient will end up with growth disturbance or not. Yes, it will predict. But accurately means, do you mean 100%? Anything in medicine we can't give guarantee, right? It is like 100% like that. But yes, to some extent up to 95 to 98%. See, there is no magic in Salter-Harris classification. What Salter-Harris tells is, if the epiphysis is involved, the growth plate reserve cells are towards the epiphysis, right? So whenever it is epiphysis involvement, the reserve cells are damaged. So whenever the reserve cells are damaged, that will result in growth disturbances. That's it. Okay. Hi, Samantha, you're back. Yes, Mahesh, that's a very beautiful question you have asked. The ulnar nerve is present on the medial side, but why their palsy? So here the answer lies in the complication. So I have told you, now listen, now this is the medial side and this is the lateral side, right? Can you identify my medial elbow and the lateral elbow? So what is happening? The lateral side, the growth has stopped. The medial side, the growth is increasing. So what is happening? It is moving outward like this, right? The medial side is increasing, but the lateral side is not increasing, right? It has stopped. So what happens? There will be stretch on the medial side. So because the growth is going towards valgus, not straight like this, it is going like this. The ulnar nerve is uh, not designed to stretch. So whenever there is a stretch of the ulnar nerve because of the progressive growth of the medial side, there is an ulnar nerve palsy. That is why it is a very slow ulnar nerve palsy. So once the patient has landed up in cubitus valgus, maybe he has got this fracture, the lateral corner fracture in 6 years, you will see ulnar nerve palsy after 16, at the age of 16 or 17 years, maybe like 10 years or more. So that is why it's called a tardy ulnar nerve palsy, because of the stretch of the ulnar nerve on the medial side, right? Mahesh, is that clear? Samantha, is that clear how cubitus valgus is formed? Cubitus valgus is nothing but, see, in the diagram you can see. So this is the elbow, right? Now here it is moving deviated away from the body. So this is valgus. When it is towards the body, it is varus. So that is your gunstock deformity. When it is away, the distal part is away from the body. This is called the valgus. So here what happens? Because the medial side there is a stretch, the ulnar nerve is also damaged. Okay. Samantha, did you get? Yes, okay. So that is your tardy ulnar nerve palsy, right? So now these are the complications, and one more important complication which you have to remember is the osteoarthritis, because again the joint is involved. This patient may result in osteoarthritis. Okay, so these are the important complications. So whenever there is a lateral condylar question in your prof exams, so these are the important points. So the first point you're going to tell that this is seen in both pediatric and adults. It is an intraarticular fracture. The mechanism of injury is varus, and here patient will come with signs and symptoms of pain, swelling of the elbow and all, and you will take the x-ray both in the AP and the lateral, and then you're going to tell in detail about the Milch classification, because we have learned in great detail, and you're going to mention in underlined words that this correlates with the Salter Harris, so which is what, and then you're going to tell about the treatment, and complications are very, very important. So non-union cubitus valgus with tardy ulnar nerve palsy, and sometimes it may also land up with osteoarthritis. Okay, clear? So now what would be the treatment for this tardy ulnar nerve palsy? Just to complete the treatment of complications. So that is called anterior positioning of the ulnar nerve. So what they will do, they will try to reposition the ulnar nerve, which is called as the anterior positioning of the ulnar nerve, right? So that is much, if you remember, it's well and good. Okay, that completes the lateral condyle. Fine. So that is about the, yes, very good. So that is about the supracondylar and lateral condylar. Now we are coming to the distal radius. So distal radius is also supposed to be one of the most important topics. Yes. The basic difference between osteoarthritis and osteoporosis. Osteoarthritis is something related with the joint. Osteoporosis is something related to bone, right? This is the basic difference, right? So whenever you're talking about the bone density, the bone quality, you talk about the osteoporosis. But when are you talking about the joint, arthros is joint, itis is inflammation, right? So osteoarthritis is nothing but it is the inflammation of the joint. Why it is occurring? Because of the degeneration. Understood? Osteoporosis is the bone. So the bone can become weak, the density can become decreased. So when you see the bone density is decreased, then you say the bone is osteoporotic. Here you say the joint is arthritic. Okay? So that is the basic difference. We will deal it tomorrow, where we are discussing about the metabolic bone diseases. Yeah. But both osteoarthritis and osteoporosis will occur in elderly patients, right? Osteoporosis occurs in elderly because as they grow, as they age, the density of the bone decreases. And osteoarthritis, because it is a degenerative condition, as the age increases, they'll end up in osteoarthritis. Okay. Yes, and now we are going to deal with the fractures of the distal radius. And before telling you various fractures, let me tell you the names of the distal radius fractures. So we are going to deal with three important fractures here. The first one being your Colles fracture, the second one being your Smith fracture, and the third one your Barton's fracture. So now sit tight and listen to all these three fractures, which are very, very important for your theory, for your practicals, for your NEET PG. Okay. So the first and very foremost one, most important one is your Colles fracture. So whenever somebody is asking you what is Colles fracture, you're going to tell the definition as it is an extra articular fracture of distal radius. So this is an extra articular fracture of the distal radius seen 2 centimeters at the corticocancellous junction. 2 centimeters from the wrist joint at the corticocancellous junction, right? So this is the definition, but this is only half of the definition. So when do you complete the definition? So it is an extra articular fracture of the distal radius 2 centimeters from the wrist joint at the corticocancellous junction. That means it is seen in the metaphysis of the radius with dorsal displacement of the fracture fragment. So this completes your definition of the Colles fracture. So yesterday we have learned displacement, right? See, it is helping you so much. So your basics and the foundation has to be very, very clear so that you don't depend on the mnemonics for your exam. So now I have told you three important points here. So the first point you have to remember about Colles is it is an extra articular fracture. So what do you mean by extra articular fractures? Extra articular. Articular means arthrus means just now I told it is joint. So this fracture is not involving the joint. So we are safe. So whenever something is not involving the joint, we are safe because articular fractures has to be dealt with great detail because movements occurs at the joint. So the movements has to come out. When you operate on it, the movements has to be perfect. So whenever the joint is involved, we are little bit worried about the movements post-operatively. But if it is an extra articular, we are little safe and the outcome is good in the extra articular fractures. So this is, yes, very good. So this is an extra articular fracture. And the second point, what I told you, this is at the corticocancellous junction. And the third point, this is the dorsal displacement. Now come back, now come here and see. So all the 3 points. So the first at the corticocancellous junction. So this is the cancellous bone, right? So this is the cancellous bone. This is the cortical bone. So this is the cortical bone. So cancellous bone is weak. Cortical bone is strong. Whenever there is a transition from strong to weak, that becomes the weakest point. Like whenever you are in your 10th class and when you come to engineering or any professional like the medical school, the transition period is very, very weak, right? We tend to cry, we tend to, hate ourselves, we don't believe in ourselves. But once you become strong, then you will understand your worth, right? So whenever there is some transition from one part of a life to other part of the life, it is always difficult, right? So that would be the weakest area. So that would be the weakest part of your life. Similarly, whenever the bone is, transitioning from the weakest to strong, that is the weakest part. So that is the corticocancellous junction. And in particular, this is weak in osteoporotic females. So this is a fracture of osteoporotic females post-menopausal. So when somebody is suffering from osteoporosis, you can see this type of fractures in them, right? It's not outside the joint, it is away from the joint. Extra articular, away, not outside the joint, okay? So usually we see this in osteoporotic females and in the postmenopausal women, right? Postmenopausal women. And sometimes patients who are much on corticosteroids, because again, osteoporosis is playing a role here. So these are the causes of the Colles fracture. And what is the mechanism of the injury? The mechanism of injury is again outstretched hand and some amount of dorsiflexion of the wrist. right? So some amount of the dorsiflexion of the wrist, something like this. So whenever you're falling like this, so because of the dorsiflexion, what happens is, this is very, very important. Samantha, see, what I'm trying to tell is, this is the diaphysis, right? And this is the epiphysis, and this particular part is called the metaphysis. So here this part is made cancellous bone, metaphysis. Diaphysis is cortical bone, right? And now this is the junction. So this is the junction, cancellous bone, cortical bone. So this is the junction. So this is the cortico-cancellous junction in the metaphyseal area. Okay. Okay, now what are we understanding here? So we have understood that the extra-articular fracture, we have understood the cortico-cancellous junction, and the third point what you have to understand is the dorsal displacement. Very, very important. Only if this dorsal displacement is present, then only you call this as your Colles fracture. Otherwise, it is not a Colles fracture. Okay, now what is happening? How do you tell the displacement? Based upon the distal fragment. So this becomes the proximal fragment. This is the distal fragment. Proximal fragment is towards the head. Distal fragment is away from the head. So if this distal fragment is moving dorsally, that means this is a dorsal displacement. So this is a dorsal displacement. Sometimes there is no complete displacement, but there could be a tilt. So even dorsal tilt is also a Colles fracture. Okay. So anterior and posterior is seen on the lateral X-ray. Medial and lateral is seen on the AP X-ray. So this is the anterior posterior X-ray. This is the lateral X-ray, like AP view, lateral view. On the AP view, what will you decide? Whether the fracture is moving to medial side or the lateral side. On the lateral view, you will decide whether it is moving anteriorly or posteriorly. When it comes to hand, you say it is ventrally or dorsally. Okay, or palmar or ventral or dorsally. Okay. So that is how you decide. So now whenever this such Colles fracture is present, the patient will present with what deformity? What deformity? This is called your dinner fork deformity. So this is called your dinner fork deformity. So that hunch of that dinner fork is called the dinner fork deformity, right? So this is all the first paper. You're going to write the definition, the causes, where it is commonly seen, and what is the mechanism of the injury. And then you come with the pathoanatomy. So I already told you the pathoanatomy. Here the fracture runs in the cortico-cancellous junction, and I have told you there are various displacements. So there could be dorsal displacement, dorsal tilt. In the AP view, if you see a lateral displacement or a lateral tilt, and finally the impaction. So yesterday we have read that the displacement can be angulation, rotation, translation, or impaction. So even if the fracture fragments are impacted in the cortico-cancellous junction, still we call this as the Colles fracture, right? And finally, if it is in supination, if the fracture fragment is in supination, completely tilted, so this is called supination, and these are the various displacements which will describe your Colles fracture. So this is the APV I told you. So here you can see the lateral displacement and the lateral tilt, right? And in the lateral view, you can see the dorsal displacement and the dorsal tilt, right? So this is about the Colles fracture. Now you see, so here you can see that this is the Colles fracture, right? At the cortico-cancellous junction, which is 2 centimeters away from the joint. And in the dorsal X-ray, you can see some tilt towards the dorsal side. So this is called the Colles fracture. So this is called the Colles fracture, right? And now what are the signs and symptoms of the Colles fracture? So first, the patient will present with the history of trauma, right? And then you will see the swelling, tenderness in that particular area. Then you see the deformity we have discussed, the dinner fork deformity, right? So these are all the various signs and symptoms. And now you order for the X-ray. Again, in the X-ray, what you see the AP view and the lateral view, and then you decide whether it is a Colles fracture or not. right? And then you come for the management. So how do you manage this case? So management is again very, very important in case of Colles, right? Yeah, in management, what is very, very important is, because this is not an intra-articular fracture, usually we go for what is called the conservative treatment. So conservative treatment is nothing but we are not operating it, so there is no surgical treatment. So conservative, so usually we go for conservative treatment, but there is also surgical treatment. So either we have to decide whether you're going surgically correction or conservative. So conservative is nothing but what we do, we put the Colles cast. So this is called the Colles cast, and this is one of the favorite question of the examiner. So how do you apply the Colles cast? Before applying the Colles cast, what you have to do? You have to reduce the fracture. So we are going to reduce the fracture and we are going to maintain the fracture. So this maintenance of the fracture is through your Colles cast, right? So how are you going to reduce? So these are the maneuvers you have to remember. So any fracture, always what happens is, remember, this is one fragment, this is one fragment. Always the fracture fragments gets locked like this. Any mechanism that gets locked. So you should always disengage the fragments, correct that, and then you have to engage it. That this is called the reduction. So they're like this. Now always disengagement, correct the position, and then reduce it accurately, right? So how are you doing that? So here we do a controlled traction. So here the fragments are like this, then you give a controlled traction. What they do, like they become little apart from each other. Then what you do, then you make the appropriate corrections to it. Whether if this has gone medial, you correct it to the center. If it has gone lateral, you correct it to the center, and then you fix it in a position, right? So that is the, those are called the maneuvers, reduction maneuvers. So here what we do is, first you give a traction, so that will disengage the fragments. Then what you do, you have to correct the dorsal fragment, because now the fragment is like my watch, it is on the dorsal side, right? Now what you do, you will press with the thumb, you press it down. So while pressing it down, what you have to do, you will do a palmar flexion, right? Palmar flexion, and then you do a ulnar deviation. So first it has come up, so you're pressing it down, right? And then because it has come towards the lateral side, you're pushing it to the medial side. So palmar flexion followed by your ulnar deviation. So this is how you reduce the Colles fracture. So this is the correction of the tilting. So dorsal tilt is corrected by your palmar flexion, right? And then your radial tilt or the lateral tilt is corrected by your ulnar deviation. Is that clear? No mugging up, no mnemonics, pure concepts, okay? So this is how you reduce it. So once you reduce it, so you do the palmar flexion by correcting the dorsal tilt, you do the ulnar deviation correcting the medial tilt, and now you take a check x-ray. So there's a C-arm in the OT. So we take a check x-ray and you see the correction. So if you're satisfied with the correction, what you do is you apply this particular Colles cast. So what is this Colles cast? So Colles cast here you do till the radial head. So this is the radial head. So you have to palpate the lateral epicondyle first and then come slowly downwards and feel the radial head. So this is the below elbow cast. So below elbow, we're just putting it below the elbow, and here it is up to the metacarpal heads. So these are the metacarpal heads. So this fracture extent, I mean like the cast extent is from the radial head, that is near the elbow, to the metacarpal heads, right? Okay, so this is how you apply the cast, and you see the thumb is free here. So you see the thumb is completely free here. Then now how you differentiate between scaphoid cast? So scaphoid, you see a glass holding cast similarly like this, but in that what happens is the thumb is enclosed, because this is the scaphoid, this is the scaphoid, so thumb is also enclosed. So thumb is also having cast here, but here the thumb is completely free, and now this is in palmar flexion and ulnar deviation. So this is your Colles cast, and this is your maneuvers which you're going to do. So how many weeks you're going to put this? So you're going to put this up to 6 weeks. So again, fracture healing is very important. I told you 3 weeks because it becomes sticky, and 6 weeks where it forms the hard callus, right? So it is the process where the hard callus is formed. I told how to reduce the fracture. Yes, there will be lots of pain in reduction. So sometimes what they will do, they give fracture hematoma block. So this block is something like the hematoma which is present. No, it has a lot of growth factors and all I told. They give some anesthesia to it. So this fracture hematoma sometimes acts as this block sometimes acts for reducing the pain. And sometimes what they give small anesthesia and then they will reduce it and then they will put the cast. Okay, that again depends upon the patient and the surgeon. So you require two surgeons here. I mean, like, one is a surgeon, the other one is called the assistant. So the surgeon holds the hand like giving a shake hand. So the first picture you can see, like, we are holding it by giving the shake hand, and then you will pull it and the assistant holds it at the elbow and he will pull backwards. This is called traction and this is called the counter traction. So when these two are acting, the surgeon will reduce the fracture. So he will do the palmar flexion and the ulnar deviation, right? So this is only the procedure, Samantha. So this is the surgeon's hand here and this is the assistant's hand. So this is called the traction and this is called the counter traction, right? And once you give traction and counter traction, here what we do the with the help of the thumb. What is he doing? He's pressing it down. So this is the palmar flexion and again he will do the tilting towards the ulnar side. So this is called the ulnar deviation. Okay. So this is about the Colles cast. So this is about the Colles cast. Now, can all the fractures be reduced by conservative method? No. Few fractures require treatment. So that particular treatments are K wires, right? If the fracture is not holding properly. So what we do, we put the cast and after 1 week we take a check X-ray. And if that in X-ray you see that again if the fracture fragment is displaced, then you go for the fixations. Or sometimes bones become very osteoporotic, so you will decide to put them with the K wire. So this is the K wires which we use. Okay, what type of comminuted fracture, which bone? And sometimes what they do, they also put this X fix. So this is called the X fix. So you see, these are the two small shunt spins which are present in the metacarpals and two in the radius shaft. And now what is happening here? What is happening here? So here you have to understand there is one more concept which is happening here, because the distal radius and the carpus are made up of multiple ligaments. So they have come up with a concept which is called as ligamentotaxis. What is this ligamentotaxis? So by putting this X fix, so you're putting the X fix here and here, and now they tighten the X fix in such a way that these ligaments get tightened. So once the ligament gets tightened, they will hold this distal fragment in this position. And sometimes if there is a small fragment which is not connected, then you can fix this with the K wire. Okay, so this is called as the X fix. Okay, this is called as the X fix, that is the external fixator, and these are called the small K wires which are used for the fixation. Samantha, you have to get two views anytime. Always orthopedics is rule of two. Rule of two, first rule, always get two views for any fracture. Always one joint above, one joint below. Always compare, because there are two limbs, always compare. Okay? These are the rules of two in ortho. Okay, so this is the treatment part, that is the management part of the Colles fracture. And what is again the most important thing of the Colles fracture is again its complications. So there are certain complications again which you have to remember in case of Colles fracture as well. The first one being, what is the first one? The first one is the finger stiffness, because you have seen that we are going to put, so if you see that we are going to put the cast, right, and we advise the patient to move the fingers, but patients they don't listen to us, right? So they don't do anything because they are afraid that fracture might move and they will cause pain and all. So that is why they don't have this movement, and later when we remove the cast after 3 or 6 weeks, they result in finger stiffness. So this is the first thing which we see in Colles fracture. And the second one, can somebody guess what is the most important complication we see with the Colles? Malunion. So now as we go on with the fractures, you are listening to these words, right? The malunion, the non-union and all. So you have to remember this. So they will ask you in the question, which of the following fractures result in malunion? So Colles is one such fracture. So Colles is one such fracture which is known for its malunion. So what is the malunion? So whenever you hear this word malunion, you have to be sure that this will result in some deformity. So again, what is that deformity? You all know that is the dinner fork deformity. So that is your dinner fork deformity. So this is one of the, again, an important complication which you have to remember. And the third one is the carpal tunnel syndrome. Now going back to your anatomy, the median nerve, where is the median nerve present? Exactly where the Colles fracture is happening, right? So sometimes this patient might land up with the carpal tunnel syndrome, which is irritating your median nerve. And the fourth one is your, yes, it is a deformed healing. Deformed healing, yes, complication of healing where the fragments are mal-aligned, right? Okay, so the what is the fourth one? Fourth one. Can somebody guess again? So finger stiffness, I told you, malunion, carpal tunnel syndrome, and Sudex osteodystrophy. So this is one of the very discouraging diagnosis for the patient as well as the surgeon, because this has no treatment. Sudex osteodystrophy is nothing but complex regional pain syndrome. It is called as CPRS. This is because of the excessive stimulation, you know, sympathetic overactivity, they say. This is because the patient will have all the symptoms like pain, hyperesthesias, the skin becomes very dry there, and number of how many, I mean, like how many times you give physiotherapy, you give treatment, you treat her with analgesics, you treat with whatnot, every drug, but the patient is still unhappy. So this is called the Sudex osteodystrophy. Okay, you have to remember that whenever you're dealing with Colles fracture, especially in the elderly female patients, sometimes they'll end up in this Sudex osteodystrophy. They keep coming to the OPDs again and again, telling about, you know, hyperalgesia. So the pain sensitivity is also increased. So they will have a lot of pain, and they will have this tingling and numbness, and the skin becomes very dry. Sometimes the changes in the nails and all this you can see. And on the X-ray, you see the bone becomes weak, which is called as the osteopenia, right? So this is all this is diagnosis of exclusion. So you have to ask the patient the complete history, and after diagnosing everything, nothing is fitting in, then you tell that this is Sudex osteodystrophy, right? And there is then one more tendon which is usually damaged, extensor pollicis tendon. Extensor pollicis. So this is because it is getting, you know, as we treat the fracture, or because of the malunion, this tendon gets rubbed over the fracture and sometimes it gets damaged. So there is a rupture of this EPL, extensor pollicis longus tendon, right? So these are the complications of the Colles fracture which you have to remember. So the main first thing you have to remember is the malunion, then the carpal tunnel syndrome, then the Sudex osteodystrophy, right? So these three are very important. So that is the Colles fracture, right? Yes. Then we are going to one more important fracture, that is reverse Colles fracture. So this is nothing but your Smith fracture. So everybody are with me, or are you okay? Any doubts in the Colles fracture? Yes? Okay. So what is a Smith's fracture? The Smith's fracture is, what is a Smith's fracture? The Smith's fracture is nothing but they tell it is a reverse Colles fracture. So if you're getting a Smith fracture in the exam, you have to be extra happy, because you're going to write something which is not usually asked, but you know everything about it. Okay. So the Smith fracture is nothing but it is again an extra articular fracture, again in the same corticocancellous junction. But what is the twist here? The displacement. Here the displacement is volar displacement, right? So there it was dorsal displacement, here it is the volar displacement. Sudex osteodystrophy is usually seen in the elder postmenopausal women because there is no particular reason because of it. Usually, these people they'll end up in the severe pain and the dryness and all. See, that is no, there is no specific cause of why these people only land. It is not like that. Even the youngsters also can land in that problem. But usually, because this Colles itself is seen in the elderly population, no, so it is registered in my mind like that. No, usually whenever we deal with this Colles fracture, especially old age women, we tend to diagnose it with CPRS. Yes, Smith's fracture is also an extra articular fracture. It is also in the corticocancellous junction. There is no, what do you say, correlation between estrogen and Sudex osteodystrophy. But osteoporosis, yes, osteoporosis is related to estrogen. So because of the lower estrogen, they'll end up in osteoporosis, but nothing to do with Sudex osteodystrophy. Okay. Now, Mahesh, don't confuse Samantha. Again, she will now ask why estrogen. Okay. So now this is it. So now this is it. So the Smith's fracture, so it is an extra articular fracture. It is occurring in the corticocancellous junction. But what is most important here? The volar displacement. So what do you mean by volar displacement? Exactly opposite to your Colles fracture. So now come back to this diagram. So now Samantha, volar displacement. I told you what is dorsal displacement. Exactly opposite to it is volar displacement. So this is called a dorsal part. So if the fracture fragment is moving dorsally, that means this side, it is called dorsal displacement. If the fracture fragment is moving this side, then this is called the volar displacement. Here you can identify it. I know for Samantha only I bought this X-ray. Now can you see? So again, can you see the three important things? This is the extra articular fracture here, right? The corticocancellous junction. And here if you see, this fragment is moving volar. This is called the volar displacement. And now go back to your dorsal displacement of the Colles fracture. So now if you see, this is moving dorsally. So this fragment is tilted dorsally. It is moving dorsally. This is called as the Colles fracture, or ventral or volar or palmar. All three are the same. And this is called your Smith's fracture. Okay. So if it is a ventral, if it is a volar, or if it is a palmar. Okay, you have got confused with the word volar. Oh, sorry then. So volar is nothing but ventral and palmar. All three are the same, right? So whenever you see this displacement, this is called as the Smith's fracture, and rest everything is same. Okay, it is also seen in elderly population. Smith is usually seen in elderly population. This is also fall on outstretched hand, right? Fall on outstretched hand. Not osteoporosis, it is osteoporosis. Arya. So now this is the Smith's fracture, where you see that it is also seen in the outstretched hand. So where we fall like this, again falling on the palm can sometimes lead in the Smith's fracture. So how do you identify Smith's fracture? So how do you identify? But the word osteoporosis is also good because of lack of estrogen. Okay, now we are deviating. Okay, fine. So once So now again everything is same. Now you take the X-ray. Now you see there is an AP view and a lateral view. And in the AP and the lateral view, what you see again, you see there is a fracture, and now it is in the lateral view. You see there is a volar displacement. Okay, then or the ventral displacement. Then it is called your Smith's fracture. And again, how you treat it? You can treat it either conservatively or because of this volar displacement. And because if you remember, the flexors on the volar side are little strong, so usually they tend to go for a surgical fixation in case of your Smith's fracture. So Smith's fracture, mostly it is surgical fixation. In the Colles fracture, mostly it is conservative treatment, right? And here what happens is one more important thing. Again, the complications are all also same with that of your Colles fracture. Here also it results in malunion only. So what is malunion here? So I have told you malunion results in a deformity. So in the Colles it was dinner fork deformity. In Smith, what would be the deformity? The name of the deformity, because it is volar nerve. So this name is given as the garden spade deformity. Very, very important MCQ. So garden spade deformity is seen in your Smith's fracture, whereas your dinner fork deformity is seen in your Colles fracture. Is that clear, guys? Okay. Now, can you identify whenever you given a distal radius X-ray, you can identify whether it is a Colles fracture or Smith's fracture? Easy, right? Yes. So this is about your Smith's fracture. Okay. Now going to the second and the last distal radius fracture. It is called your Barton's fracture. It is called your Barton's fracture. Now this becomes a very, very important fracture because this is an intra-articular extension. So whenever there is a distal radius fracture with the intra-articular extension, which means this is a fracture dislocation sometimes. That means the joint, the wrist joint is involved. So whenever you see a distal radius fracture extending into the joint, this is called as your Barton's fracture. Okay. Now, the twist is this Barton's fracture can again be two types. It could be a volar Barton's or a dorsal Barton's, right? So it is again of two types. It either could be a volar Barton's or a dorsal Barton's, depending upon the displacement of the fragment. Don't get confused. I have brought the X-rays. So now you see. Now what is the difference here? Still now what we have learned is the extra-articular fractures which are not involving the joint, right? So here I'm teaching you the fracture which is involving the joint. If you see the joint line here, you can see there is a small fracture. So this is called the Barton's fracture. So whenever you see a distal radius fracture which is involving the joint line, this is called as the Barton's fracture. And now this particular fragment again can go either dorsally or ventrally like this. So if this fragment goes dorsally, this is called as a dorsal Barton's. If it goes ventrally, this is called as volar Barton's. Clear? So any Barton's, because I have told you this is intra-articular, treated as fracture dislocation, it is treated surgically. So there is no role of conservative treatment. You have to operate it. So it is treated surgically. And again, coming to the pathoanatomy, it is similar. Pathoanatomy is same for all the three. What you have to remember is the wrist joint, right? So we are more concerned about the joints, right? I've told you. So this is the wrist joint here. And you can see there is a scaphoid and lunate. So these are the two carpal bones which the radius forms the joint. And not to forget, you have your small cute ulna which is sitting along with the radius. So this is the anatomy, the pathoanatomy, and everything should be taken care of whenever you're fixing the wrist joint. So this is called the articular surface of the radius, and this is called the articular surface of the ulna, and there is a small joint between these two, the membrane which is present, that is also should be taken care of. And this articular surface usually faces ventrally and medially. That is what you have to remember. So anatomically what happens is this articular surface is always ventrally, that is palmar facing, and medial facing. So that is why whenever it is dorsal facing or dorsally dislocated, it is called as a Colles fracture. Right? And now you have to remember this distal radius styloid process. So this styloid process is way little higher compared to the ulnar styloid process. So these are two other anatomical points which you have to remember. So this is what I'm talking about, the articular surface. So whenever we are talking about orthopedics, it is not as easy as we see. Right. So what do you mean by this articular surface? Articular surface is nothing but this is the articular surface. So if you see, this is the articular surface. And now this is the scaphoid and this is the lunate. So this is the scaphoid fossa, this is the lunate fossa, and this is your ulnar styloid, and this is your radial styloid. And if you can see, the radial styloid is at a higher level compared to the ulnar styloid. So this is the normal anatomy. And now what is happening? If you see here, this articular surface, now it is tilting like this, right? So this articular surface is usually, whenever you see in the normal x-ray, so normal x-ray, so this you see, this is slightly ventrally. So this is the normal one which we usually see, the articular surface. But here there is a fracture. The fracture is here. But usually the surface should be like this, slightly towards palmar side. So it is like this, slightly towards the palmar side. So that is what it is called as. The articular surface is ventrally and medially. Okay. So that is the pathoanatomy of the distal radius. So this can, you can write for all the three fractures. And coming to the Bartons in particular, what I've told you, it is an intra-articular fracture. Then we have two types of fractures depending upon the displacement, the volar Bartons and the dorsal Bartons, right? And in the Bartons fracture, what you treat, mainly the treatment is surgically, and that particular treatment is plating. So they usually go for a volar plating, so that they have to buttress. So this particular fracture which is there, so you are going to fix this fracture by putting a plate. So you will put a plate like this, so that this fracture will get into and sits into that particular bone, right? So this is called the volar plating. So what is the treatment of this? This is plating. So why plating again? Because this is a periarticular fracture, and we have already decided yesterday that whenever we don't want callus to form, especially in the joints, we go for absolute fixation where we don't want any callus. No callus is primary, direct healing. Okay? Clear? Connected? Any doubts? So again, complications of the Bartons, mainly what would be the? It would be again osteoarthritis because the joint is involved, right? Again, it could be median nerve. So median nerve also can get trapped because of the position. The palmar, it is volar Bartons or palmar Bartons. Again, the median nerve can get damaged. So these are the complications of the Bartons fracture. Clear? Clear. Okay. Arya Kumar, you are from which prof? Okay, so that completes the distal radius fractures. Now let us go to hand injuries. So in hand also we have certain fractures which are again very, very important. You have to, oh, third prof. Okay, good, good. Okay, now coming to the hand injuries, one of the most important hand injuries or the fracture dislocations. So here what we are going to read about the metacarpals, okay, and then the phalanges. Yes, he should be the topper. And then about the joints, the carpo-metacarpal joints, right? So these are the things which we read in the hand injuries, right? So in the hand injuries, the most important thing what I'm going to teach you today is about the CMC joint. So the first metacarpal joint base or metacarpal base. Let us understand the first metacarpal base. So why I'm talking about this first metacarpal base is there are two important fractures which you have to remember. The first one is called the Bennett's fracture and the second one is called the Rolando fracture. Okay, Bennett's and Rolando. Okay, so now we are going to understand what is Bennett's fracture and what is a Rolando fracture. So what is the definition of Bennett? So this is the Bennett's fracture, right? Definition of Bennett's is it is a fracture subluxation of the CMC joint, that is carpus trapezium and the metacarpal. Understood? So this is the metacarpal what I'm showing you. So this is the metacarpal, the first metacarpal, and this is the carpal. So this is carpo-metacarpal joint, the CMC joint, right? The CMC joint. And here the base of the joint is damaged. So what is that fracture which is happening here? Can somebody describe or read the fracture for me? So it is the fracture which is involving the base of the first metacarpal, that is the thumb. And what type of fracture is this? All average students are supposed to be the most successful doctors, Arya. So be happy that you're an average student so that you'll become a very good successful doctor. I mean, clinically. So now, yes, Mahesh, yesterday, Samantha, all you, what is this fracture? Is this a spiral fracture, transverse fracture, oblique fracture, segmental fracture? What fracture is this? Displaced, yeah. Now don't tell me it is a simple fracture, Mahesh. Tell me the pattern of the fracture. Faster, faster, we have to complete by 8. So this is an, okay, it is displaced, accepted. Then next. Very good. This is an oblique fracture. So this is an oblique fracture. So first 3 important points which you have to remember is segmental. No, Samantha, there is no segment here. This is the base, the end. No, it's the end of the metacarpal. So it is an intra-articular fracture which is involving the CMC joint. It is an oblique fracture, right? And there are fragments, there are vols, again it could be a volar fragment or a dorsal fragment again. So remember, don't remember this volar dorsal, this is not required. What you remember is these 2 things. So it is the first, whenever somebody is asking about the Bennett's fracture, first you have to tell this is the base of the first metacarpal. It is an intra-articular fracture which is very, very important because it is involving the CMC joint. And then it is a oblique fracture. This is an oblique fracture. It has 2 fragments. It has 2 fragments, right? So why I'm specifically telling it is a bifragment oblique fracture? Because it has a friend who is called Rolando, where you can see 3 fragments. Again, the fracture is same here. It is again the base of the metacarpal only, the base of the first metacarpal. This is also intraarticular, but the fragments are more than 2. That is 3 fragments. This is called Rolando fracture, and here this is called the Bennett's fracture. Then what is the importance of this Bennett's fracture? Whenever somebody says it is intraarticular, the reduction has to again be perfect, right? So because it is a joint, so perfect reduction has to occur. But what is that which is obstructing the perfect reduction? Here, this is the culprit, the abductor pollicis longus tendon. So the APL, the abductor pollicis longus tendon, is been attached to this longer fragment. So this is the longer fragment, right? So to this fragment is the abductor pollicis longus, APL is attached, and this is pulling it in abduction. And you can see the small chutki fragment there, the small fragment. This is still attached to the trapezium, and you can see the ligament. Okay, so because of this, the small fragment is still attached to the trapezium, but the larger fragment is coming down to abduction because of the pull of the APL tendon. APL tendon. So this is very, very important whenever you're trying to talk about the Bennett's fracture. This is what you have to write in the exam, right? So 3 points. First of all, it is a fracture subluxation of the CMC joint. Because it is a fracture, this subluxation, it is an intraarticular, and it is a bifragment oblique fracture, and the larger fragment is being pulled by your APL, and because there is a pull of the tendon, the reduction is not, you cannot reduce it conservatively, so you open it, perfect accurate reduction with K wires, right? And then you maintain it with slab or cast. So that is the treatment, and that is about your Bennett's fracture. Okay, now coming to its friend. I told you this CMC joint. So the first metacarpal base, again he's having one more friend, that is your Rolando. The Rolando. This Rolando is Subluxation is what? Then I have to teach you what is dislocation and subluxation. So here, if you think this is a joint, so this is a glenoid, and now this is my humerus. So this is a shoulder joint. So what do you mean by dislocation? Dislocation means completely the whatever the head is coming out of the glenoid. So the joint is, the articulating surfaces are completely different, or they have moved completely, divorced. Okay, what is subluxation? Subluxation is there is slightly some contact still present. Though the humeral head has come out of the socket, still they are maintaining the surface, articular surfaces are in still touch. So that is called as subluxation. So this is the difference between subluxation and dislocation. Okay. So the articular surfaces are still in contact, it is subluxation. Completely out of contact is dislocation. Okay. So if you see here the articular surfaces, so this is articular surfaces, right? So these are still in contact. Okay. So this is not complete dislocation from the trapezium. Okay. This is not about the fracture fragments. This is about this joint, the metacarpal and the trapezium. Okay. So this is subluxation. Clear? Understood? And now this Rolando fracture, this could be in shape of T, in shape of Y, or comminuted fracture. So this is a comminuted fracture, right? So either in the shape of T or in a Y, this is a comminuted fracture in the first metacarpal base. This is called as the Rolando fracture, and this is also an intra-articular fracture. Without doubt, this is an intra-articular fracture. Okay, but the treatment is not so perfect because of multiple fragments. We can't go for perfect reduction of this particular uh, fracture, right? But here, because this is bifragment oblique, you have to go for a perfect reduction. Okay, and now what is this? Now, I told you this is the base, this is the shaft of the metacarpal, this is the neck of the metacarpal, and this is the head of the metacarpals. Okay, these are the naming nomenclature of the metacarpal fractures. And now can you tell me what is this pointed one? What fracture is this? We have discussed this clearly yesterday also. What fracture is this? Can everybody notice there is a fracture? So usually the metacarpals are named like this, no? From the thumb, it is called the first. This is the second. This is the third. This is the fourth. And this is the fifth. So I've given you the clue. It is a fifth metacarpal. Which structure is fracture? Is it the head, neck, shaft, or base? Yes, faster. So this is the fifth metacarpal neck fracture, right? Fifth metacarpal neck fracture. Yes, fifth metacarpal neck fracture, and you can see there is slight volar angulation. Okay, so whenever you see a fifth metacarpal neck fracture, this is also called as your boxer's fracture. So this is not the head, it is the neck. You can see the fracture is here, not here. So whenever it is head means it is again the joint, the MCP, MCP, metacarpophalangeal joint will be involved. Here it is not the joint which is involved. This is only the neck fracture. So this is called as the boxer's fracture. Very good. So this is called the boxer's fracture, and the mechanism of the injury here is fist. So somebody has made this fist and they punched like this. So because of this punching, there is a fracture in the fifth metacarpal neck fracture. So this is called uh, boxer's fracture. Okay, and this fourth and fifth metacarpals are very, very important for gripping. So that is why you have to treat them properly. You have to treat them properly. So this is a boxer's fracture which requires proper treatment, and because this is an impacted fracture, so you can see that the fracture fragments are impacted here. Hence, because of impaction, they are stable. Hence, you can go for a conservative treatment in case of your boxer's fracture. That means you give a casing. So cast is applied for this particular fracture. So this is the boxer's fracture, and you will deal with the casing, right? So these are metacarpal fractures. Okay. Now let us understand few soft tissue injuries which might occur. Neck fractures here. This is the neck fracture. So this is the, okay, this is the head, this is the neck, shaft and base. So between the head and shaft is the neck. So this is the neck fracture. Okay. Yes. And now these are two important again injuries. If they're asking you in the exam, I am like, they might ask you this again. So there are two type of fingers which can occur. So one is your mallet finger. The second one is your jersey finger. Just remember the names, the mallet finger and the jersey finger. Okay. Scaphoid fracture, yeah, I will tell you after this. Once complete this mallet finger, then I'll tell you the scaphoid. So mallet finger, whenever the mallet, so mallet is something like this, no? This happens, this mallet finger is snap sound which will occur, and now the finger goes into flexion and patient cannot extend the DIP, right? So this is the phalanx which goes into flexion like this, and now patient cannot do. So this DIP, only DIP movement I'm doing here. You have to hold the PIP and then ask the patient to do this. Okay. Can you see? Okay, he will not able to do this movement. Okay, so why he will not able to do this movement? Because there is an avulsion injury. Avulsion, what do you mean by avulsion? Means a particular part of the bone where the tendon is attached has been come out. So that is called the avulsion injury, or there will be the rupture of the extensor tendon. So because of there is rupture of the extensor tendon, the patient cannot extend the DIP, right? So that is called the mallet finger. Whenever there is damage to the flexor tendons, similarly on the opposite side, flexor tendons, these are called the jersey fingers. These are called the jersey fingers. Jersey is this, they call this as jersey, they get hitched, the fingers get hitched here, and then they will result in the ruptures of the tendon of the flexor. So this is called as the jersey finger, and here the flexor tendons are damaged. So here what happens, because the flexor tendons are damaged, they go into extension, but it is not beyond the like this. From flexion to they become normal. So that is why you cannot diagnose it by seeing. But mallet finger, you can diagnose it by seeing just as a spotter, because the finger goes into flexion and patient cannot extend it. Because the finger goes into flexion, that is called as the mallet finger. Yes, one of the most common carpal bone fracture is scaphoid. It is very common. So that is it. Just remember this: the mallet finger, the jersey finger. Treatment part, you can give a conservative treatment. When you can give conservative, if there is only a rupture of the tendon, you can give splints. Okay, and if you want to repair, you can repair the tendons. And avulsion, you can put a K wire. You can put a wire, small wire, for avulsion fractures. Yes, yeah, you can see, usually seen in football and the rugby. Yes, as Arya said. Okay, so that is about the fractures. And now, as Mahesh has asked us, let us quickly go through scaphoid fractures as well. So scaphoid fractures is supposed to be the most common carpal bone injury, right? So one of the most important carpal bone is your scaphoid, right? And this scaphoid, if you see, it forms the joint with the radius, right? And here what is important is the mechanism of injury is again fall on outstretched hand, and here the patient comes with complaint of pain in the wrist, right, and swelling, but it is not very obvious. It is not very obvious. It is not very obvious. And now you will have the tenderness in this particular area, which is called as the anatomical snuff box. So you would have read in the anatomy what is an anatomical snuff box, where So where you see this anatomical snuff box, it is an area here where the roof is, the floor is formed by the scaphoid. And if you press in the anatomical snuff box, you will have tenderness. So this is one of the most important sign which you can elicit in case of your scaphoid fractures. And sometimes the scaphoid fractures are very, very minimal. The deformity or disability is minimal, so they are usually missed. Okay, they are usually missed. So that is where what you have to do, you have to be very careful in examining and asking the history. And if the patient is having tenderness in the anatomical snuff box, don't hesitate to order for the x-rays. And these x-rays are a series of x-rays where you take AP wrist, lateral wrist, AP view, lateral view, and the most important is your oblique view. So you have to go for an oblique view in case of your scaphoid fracture. So whenever you go for an oblique view, you can see the waist fracture. So if you go back to anatomy, the scaphoid is having waist. So the middle part is called the waist, and this is the area where it is most commonly fractured, right? So for example, your scaphoid is like this S-shaped bone, right? So this is the waist. So this is the waist, the center part. And if you see, the blood supply of it is from the distal to the proximal like this. So the blood supply is from the proximal, from the distal to the proximal. So whenever there is a fracture here, this is the part which will go into avascular necrosis. So because the blood supply is cut off, this is the part. So the proximal part will go into avascular necrosis. So what is avascular necrosis? Yes, usually we have to go for PA view wrist. Yes, PA view or AP view. You can go for PA view. So for the wrist, usually we go for the PA view. But because we are used to AP view, again, I thought you will get confused with the PA view. So it is not very, very important that you go only for PA view. But if you want to choose between AP and PA, you can choose happily PA. But AP also we can diagnose, okay? Right, we can go for both the views. PA is most specific. It's important. If you take PA view, it's good. And then lateral view. But what is the most important is the oblique view. Okay. And then this is the scaphoid anatomy, pathoanatomy. You have to be very, very careful. So the blood supply is from the distal to proximal, right? So from the distal to proximal, and the waist fractures are very common. And whenever you see these fractures, there is a tendency for the proximal fragment to go into AVN. And have you diagnosed the AVN? The diagnosis of the AVN is by MRI. So whenever you take an MRI, you can see that the AVN is present, and on the X-ray what you see there is an increase of the density of the bone. It is not the lucency, you see it is more sclerotic, it is white is more on X-ray if it is a scaphoid. Okay. Yes. Okay, so that is the thing. And how do you treat it? So treatment of the scaphoid injuries is by the glass holding cast. So I've told you the glass holding cast is the treatment, right? Conservative treatment. And if you go for the fixation, you can use a screw which is called as the Herbert screw. We can use the Herbert screw. These are headless screws, and threadings are there on the both the sides. Okay, so this is the screw which is used for fixation of the scaphoid fractures. So this is about the scaphoid. So this is the glass holding position. So this is what is called the glass holding position. So this position you will apply the cast. So it will come out to be like this. Okay, and you will enclose the thumb as well. You will not have no movement of the thumb. So the thumb is enclosed in the cast. Clear scaphoid? Anything else you want me to add? Okay. Yes, good. Now just we will, okay, before that, phalanx, fractures of phalanx. So whenever there are fractures of phalanges, so what is the main important? Jersey finger is nothing but, see, jersey finger, whenever this happens, because it is called a jersey fingers, because sometimes whenever these players play the rugby or football, the finger gets caught into this and it goes into this forced extension like this. It goes into forced extension. So whenever it is going to forced extension, the flexor tendons will rupture or they avulse, right? So they rupture or they avulse. So this particular tendon is your flexor digitorum profundus. So DIP is by your flexor digitorum profundus, right? So this tendon, whenever it is getting damaged, this will result in the jersey finger. So what is jersey fingers? Patient cannot actively flex, but visually when you see, the finger is straight like this, there is no deformity. But in case of mallet, you see the finger is like this, so the DIP is in flexion, right? So that is what I wanted to tell. So that is about the jersey finger. No, yeah, the phalanx, how you do? So this is your finger. So let us assume that this is your finger, and let us think that this patient has got a phalanx fracture, for example, a middle phalanx fracture. So here what we do is, this is called the buddy strapping. So buddy strapping is, you take the support of the other finger here and you will put the tape along this. So if it is a middle phalanx like this, middle phalanx fracture, so you tape like this along with this or like this. So these two fingers we tape. We tape at the PIP and the DIP. So this is the PIP. So this is the PIP and the DIP. So tape is applied here and here. So the joints above and below are immobilized so that the shaft can heal. So that is called as the buddy strapping. Okay, this is called as the buddy strapping. Okay, buddy strapping for the phalanx fractures. Nothing else we do. So that completes the hand. Now let's go to the fractures of the lower limb. Now this is very, very important, and it is really important for your prof, again for your Viva and practicals, again for your NEET PG. So one topic, if it is important for every exam, right? So now let's not deviate or relax, but put our full focus on understanding only three important topics. Again, fracture neck femurs and posterior dislocation of the hip. So in fracture neck femurs, we have two types. One is your intracapsular fractures and the extracapsular fractures, and the posterior dislocation of the hip. So these three we're going to learn, and then we are going to wind up the class for today. Okay, so now let us understand what is a proximal femur. So before understanding what is your intracapsular, extracapsular, let us understand from basic what is a femur. So whenever somebody asks you a femur, so this is the proximal femur, then we have shaft of the femur, and then we have the distal femur. Okay, so femur, it is like proximal, then we have the shaft, then we have the distal femur. So now today we are interested in understanding the proximal femur, right? Again, when you go back to the proximal femur, there are certain divisions to it. So now this particular part is called the head of the femur. So this is called the head of the femur, the whole round structure. So this completely is the head of the femur. This, okay, this is the head of the femur. And now the connection, this is called the neck of the femur. So this particular area, this S-shaped structures, these two, these are called the neck of the femur. Understood? So this is the neck of the femur, right? And now this is your greater trochanter. So this is your greater trochanter, right? And now this is your lesser trochanter. Hence, this is called as your intertrochanteric area. This is called your intertrochanteric area, right? And whenever something is below this, below the trochanters, this is called as your subtrochanteric. So something below it, it is called sub. I don't know, Arya. I don't know that game, Warcraft game. I'm not, no idea. So have you understood it clearly? So this is very, very important. Understanding every bit, every detail is important, so that you will not depend on mnemonics, or you don't depend on somebody explaining you through stories and all. So what is purely you understand is the concept, right? Now, Nishu, please wait. You are in the treatment of hemiarthroplasty. We are just understanding what is head here. So here, this is the thing. So first, this is the head of the femur, neck of the femur, the greater trochanter, lesser trochanter, which is called the intertrochanteric area. And if you see, there is some demarcation, right? What is shaft here and what is subtrochanteric area? So somebody thinks this is all shaft, but 5 centimeters below the trochanter is called the subtrochanteric area, and this is the weakest area again. So if you see, there is a transition. So transition from the trochanter to the shaft through the subtrochanteric area. Again, I told you, whenever there is a transition in life, this will be the weakest area. So you have to be very strong, right? So this is the weakest area. So this is the weakest area. So these are the parts of the proximal femur. So these are the parts of the proximal femur. Now tell me, what is an intracapsular fracture and what is an extracapsular fracture? So here your proximal fractures can be divided into two. So one is your intracapsular fracture. The second one is your extracapsular fracture, and they have other names. This extracapsular is also called as intertrochanteric fracture or an IT fracture. So this is called an IC fracture, and this is called as an IT, that is intertrochanteric fracture. Now come back to the diagram here. So here we have understood that whenever there is a fracture neck, so if it is fracture neck, it is an IC. So because the capsule attachment is up to this particular area. So intertrochanteric crust. So you call this intertrochanteric crust, and this is all enclosed in the capsule, right? So whenever you see the fracture happening at the neck, that means it is inside the capsule, hence it is called as intracapsular fracture, and which is outside the capsule is called the extracapsular fracture or the intertrochanteric fracture. So here IT fracture. So this fracture between two trochanters is called your IT fractures. Is this clear? Very, very important to identify whether it is an IC or an IT fracture right from your MBBS, because the treatment differs a lot. Unfortunately, there is no book, but I think Maheshwari is sufficient for you all. If you still want to read more and more, you can go for Applis, but Maheshwari is good up to this level. Otherwise, you can go for Applis, but that is a huge book. I'll show you how thick is Applis. So this is the Applis. So do you really want to read this much of ortho in your MBBS or your Maheshwari? So the difference is this. So better stick to Maheshwari, and if you find something good and if you want to add, you add it in Maheshwari only. Okay, now not to deviate again. So this is an intracapsular and extracapsular, that is an IC and IC and IT fracture. Okay. So now what is the difference? Basic difference. Yeah, Maheshwari better. Nishu, you're from which prof? Which one you have? You have Applis, Arya. Yeah, I've already wrote a book. You can buy this book. So this is again everything. I have read Applis, I have read Maheshwari and wrote this book for you. So you can buy this book. It is Book of Orthopedics from PW Meded. Okay, so this has everything. Oh my God. Okay. So that is okay. Thank you. Thank you, Arya, for that. Okay, now let's not deviate again. Okay, now don't ask any questions for 10 minutes. I'll complete these fractures and then we can talk. Okay, now sir, now there is an intracapsular fracture and extracapsular fracture, right? I have told you this is the capsule. So, say why capsule is very, very important for us and what is the thing. So then what is the thing about these two? So here what is happening is when we go back to basics, and the basics are saying that the blood supply, again if you go back to scaphoid, I've told you the blood supply is from distal to proximal. Similarly for head also the blood supply is from distal to proximal. So it is going, the blood supply is going like this. So here what is happening here, whenever there is a fracture in the neck, so whenever there is a fracture in the neck, the head is solely dependent upon this blood supply. So the head is solely dependent upon this blood supply. So whenever there is a fracture neck of the femur, now listen, this head goes into avascular necrosis, or because or devoid of the blood supply, it goes into devoid of the blood supply, right? This is very important point you have to remember. But for intertrochanteric fracture, it has again very vicarious blood supply. So the blood supply is good here, it is good here. So IT, there is no problem of blood supply, right? But I see there is a problem of the blood supply, hence it goes into AVN. Before going to AVN, because there is no blood supply and because this fracture is inside the capsule, again that means inside the synovial fluid. I have told you intra-articular fractures whenever associated with the synovial fluid, because of the synovial inhibitors, again there is a chance of non-union. So there is a chance of non-union. So whenever there is an IC fracture, you have to be very careful because this might land up in non-union. Whenever there is scaphoid fracture, you have to be very careful because that might land up in non-union. Can you name one more bone where you have to be very careful because that also lands up in non-union in the lower limb? So whenever somebody is telling you about non-union, remember there are three important bones. The first one is the femur head, very, very important. The second one is your scaphoid, again important. And the third one is your talus, right? Again, all these three has a different blood supply. Okay, so this blood supply is from distal to the proximal. So whenever there is IC fracture, neck or femur fracture, there could be damage to the blood supply. Hence, this femoral head can land up in AVN, or this fracture might land up in non-union. So that is one of the most important point you have to remember in case of your IC fracture, right? So here the most important thing is age. So usually it is seen in 60 years. This is more than 65 years. So more than 65 years. That is an IT fracture. So IT fracture, the blood supply is good here. So blood supply is good here, right? And here what is happening, whenever there is a fracture happening in the neck, because it is intracapsular, the capsule is holding the fracture. So the attitude is external rotation and shortening. And here also there is external rotation and shortening, right? But when you come to IT fracture, this is more profound. So in IT fracture, you can clearly see that the limb is externally rotated. So if you see, this is the neutral limb. In the IT fracture, what happens is the limb becomes like this, completely touching the couch. So it goes into external rotation like this. So why it is going to external rotation? Because the capsule is not holding that. In the case of extracapsular, the capsule is not holding the fracture, hence it is the external rotation and shortening is more. Whereas in IC, because of the capsule, this is less seen. Means it is slightly external rotated, but not as much as seen in your IT fracture. So this is one of the most important thing which you have to remember in case of your IC and IT. And most thing I told you, the IC fractures, they go into non-union. So why they go into non-union? Because this particular fracture, it is inside the capsule, and inside the capsule means the fracture is bathed with the synovial fluid, right? Inside the capsule we have synovial fluid. So this synovial fluid will have some synovial fluid inhibitors. So fracture inhibitors are present in this fluid, which will inhibit the process of fracture healing. Hence, this will end up in non-union. Samantha, is that answered? So this will result in non-union, but the IT fracture, the most thing what you have to remember is this will result in malunion. So there is a malunion here and there is a non-union here. So this is you have to remember, right? Okay, now coming to the IC fractures. So whenever you deal about the IC fractures, first you're going to write the pathoanatomy. I have told you head, neck, and the trochanter, and the capsule is present in the intertrochanteric crust area. So the IC is present inside the capsule. So next what you will write? You will write the mechanism of the injury. The mechanism is usually what? Slip and fall. So usually they slip and fall and they will land up in this IC fracture, right? And then they will come with pain and swelling in the hip. And the first thing, they will not be able to bear weight. So unable to bear weight, because hip joint is mainly involved in bearing weight, right? So this particular patient will not be able to bear weight and they come to the casualty. And now what you will do? You order for the x-ray. So what x-ray you go for? You have to go for pelvis with both hips x-ray. So you go and you order for pelvic with both hips x-ray, which is very, very important for diagnosing your IC or IT fractures, right? And then what you do, the classification. So you will tell which type of fracture this is. So based upon the classification only we'll decide the fractures, right? So there are three types of classification in case of IT. The first one being your anatomical classification, the second one being your Powell's classification, and the third one being your Gardner's classification. So these are three important classifications which are very, very important in case of your IC fracture. Anatomical fracture is very, very easy. Going back again to this particular diagram we see, so this is the neck, right? So this is the neck. So this is the neck and we are classifying this anatomical fracture. So whenever it is right below the neck here, okay, right below the neck, this is called as your transcervical, sorry, subcapital. So right below this is called your subcapital. So capita is bone, below the head, the capitis is head, and below the capita is subcapital. Whenever it is in between, it is called the transcervical. So this is called the transcervical, right? And this particular area, this is called as the basicervical. That means base of the neck. So this is the basicervical, right? So there are three important classifications in case of your anatomical classifications. So one is your subcapital, transcervical, and basicervical. So these are the three important fractures, usually not very significant for us, right? So next classification, this is called the Powell's classification. So this is called the Powell's classification. This is also not very important, but why this classification has come up? Because to tell us whether this will heal properly or not. So whenever the angle is increasing, that means the fracture healing, the rate of non-union is increased, right? So if it is 30 degrees, so now you take, this is the fracture, and here this is the fracture, and here this is the fracture. As the fracture is becoming more horizontal, so if you see, the line is like this here, like this here, and like this here, right? So as it is becoming more horizontal, the union is difficult. So if it is 70 degrees, the union is difficult. So 70 degrees, it lands up in non-union. 50 degrees, little chances of landing up in non-union. 30 degrees, the healing is good. So that is what is Powell's, not very much used. Samantha, this is the head, this is the neck. Okay. So here we have subcapital just below the head, transcervical exactly middle of the head. This is the basicervical. Subcapital, transcervical, basicervical, right? So these are the anatomical classification. And coming to Powell's, not very important, just remember 30, 50 and 70, 3, 5 and 7, right? And these are the degrees which are made with the fracture line. So this is the fracture line, the angle of the fracture line to the straight line over the head. So there is a straight line on the head directly, and what is the fracture making with that straight line? So angle between the fracture and the straight line. So straight line is this. It is by default the straight line, okay, the perpendicular. And now coming to the Gardner's classification. So this is your Gardner's classification, which is important. So why Gardner's classification is important? Because this can be used. Okay, this can be used for your treatment. So there are 4 types in Gardner's classification. This is type 1, which is not a complete fracture. So it is an incomplete fracture. Okay, it is an incomplete fracture, sorry, incomplete fracture. So this is type 1. So it is not perfectly completed. See, it is a half, it is only till here. So this is an incomplete fracture, right? So here type 2 is a complete fracture, but it is undisplaced. So this is very important. Incomplete fracture and it is an undisplaced fracture, right? And then coming to type 3, this is a complete fracture and displaced. The displacement is partial, right? So it is not completely displaced, partially displaced. So here it is a complete fracture, completely displaced or fully displaced. Okay, clear? Fully displaced. So this is very, very important. So first we have an incomplete fracture, then we have a complete fracture which is undisplaced, then we have a complete fracture which is displaced but partial displacement, and grade 4 is complete and fully displaced fracture. So this is Gardner's, which is very important, and if you draw this, it is very, very good for you to get more marks. Okay, so this is about the classification of the IC fractures. So once you have classified the IC fractures, then what you do, this classification is mainly based upon your X-ray only, no? So now tell me, this is A and this is B. Now tell me, what is A? Which fracture is A? Is it an IC or an IT fracture? Faster. Is it an IC or IT fracture? So here you can see the fracture is, yes, this is the, so this is the fracture. So this is the fracture and it is happening in the neck and it is a complete fracture, right? So it is a complete fracture. Very good. So this is an intracapsular fracture. So this is an intracapsular fracture. Very, very good. And now coming back, Samantha, this is not an IT. You see, the fracture is where it is happening, in the neck or in the trochanter. So now, guys, till your level, if you say IC, that is more than enough. Don't worry about whether it is Gardner's 1, 2, 3, 4, until and unless it is completely displaced. Just tell it is an IC fracture, complete IC fracture. This is not an incomplete, this is a complete fracture. Okay? Okay, that is enough. IC is enough for me now. Yes, Samantha, IC fracture. Very good. Now tell me, which fracture is this? This is what fracture? This is a, so now you can see the fracture is between the greater trochanter and the lesser trochanter, right? And the neck is normally present here. So this is what? This is what fracture? This is what fracture this is? Now the head has, I am just asking whether this is an IC or IT. I am not asking you the types of the fracture. Yeah, this is an intertrochanteric fracture, right? You can see the head and the neck is intact here. So the head has been rotated completely. It is into complete valgus, right? So complete. Yeah, yes. Yeah, it is comminuted. IT fractures. Very good. So this is an intertrochanteric fracture. This is an intracapsular fracture. Very good. So now for intertrochanteric fracture, there is no classification as you can remember. So you can just remember there is a Russell's classification, but not very important. Okay, just leave it. No need to remember any classification for IT, but for IC you have to remember that this is anatomical Powell's and Gardner's classification. And signs and symptoms, I have told you the patient will come with the externally rotation and shortening of the limb, right? This is IC. This is IT. IC and IT. So this is intracapsular, this is intertrochanteric fracture. Now what is more important, not the signs and symptoms. Once the diagnosis is made, what is more important is the management. So you have to manage the case, right? So management is very, very important. And here what we do is, because we already know the IC fracture because of the vicarious blood supply to it, because the blood supply is not a normal blood supply. Okay, so that is where what we do, we depend upon the age of the patient, right? If the patient age is less than somewhere around 40 to 45 years, or if the patient age is more than 60 years, or if the patient is more than 75 years, but he should be an active individual. So that is how we divide the treatment. So here what happens is, whenever the patient is age of less than 40 to 45 years, what we do, we still try to preserve the head. We don't remove the head. So that is called as osteosynthesis. And here what we do, we try to remove the head because we are trying to remove only the femoral head. We are trying to do half replacement. So hemi arthroplasty. Hemi ka matlab, hemi means half. Arthros means joint. Plasty means replacement. We are doing a half joint replacement. So what is that half joint? We are replacing the femoral head. How do you replace the femoral head? We replace the femoral head with the prosthesis. We remove femoral head with the prosthesis. And if the patient is more than 75 years and if is a very active individual, then you give him an option of THR. So what do you mean by THR? T means total. That means total hip is replaced. So what do you mean by total hip replacement? Where you replace the acetabulum and the femoral head, which is called as a total hip replacement, right? So total hip is both the acetabulum and the femoral head is replaced. Hemiarthroplasty is only half, that is the femoral head is replaced, right? Everybody there? So now what is this? This is the osteosynthesis where we are using the cancellous screws. So we are using the cancellous screws, right? So these are called the CC screws, and inverted triangular fashion we are using. So this is nothing but for people less than 40 years of age, right? People less than 40 years of age. These are the cancellous screws. Then this is what? This is the bipolar bipolar prosthesis. So this is a bipolar prosthesis which we are using, that is the hemiarthroplasty. So why acetabulum? Hemiarthroplasty is a half hip replacement typically for femoral neck. So why here we are replacing acetabulum? Because whenever we do a hemiarthroplasty, because the patient is more than 75 years, usually they will land up, usually whenever you take the x-ray, you see that the acetabulum is also involved, resulting in hip osteoarthritis. That means that because of the osteoarthritis is a degenerative disease, right? So hip osteoarthritis. So because of that, you will see there are changes in the acetabulum, right? And once the patient is with hemiarthroplasty, and later if he is having hip osteoarthritis, again you have to treat him with total hip replacement. So that is why what we do, if the patient is very active individual, to avoid a second surgery, and we take the changes of the acetabulum into consideration, and then we'll advise for a THR. So this is also is advised for IC fracture. Which material uses for prosthesis? So prostheses are implants. These are made up of a cobalt chromium metal, COCR. It is called cobalt chromium. Okay. So this is about the treatment for your IC fracture, very, very important. Now coming for your IT fracture. So IT fracture, I have told you it is an extracapsular. So there is no problem with the blood supply. Blood supply is very good. What is the problem is the alignment. You have to properly align the IT fracture. So for this alignment is obtained by the proximal femoral nail. So this is called nailing, where you put the nail into the medulla and then two screws into the head. So this part is taken care of. So this is called the proximal femoral nail. So this is called the proximal femoral nail, right? So this is called the proximal femoral nail. Okay. So this is the PFN. So this is called the cephalomedullary nail. So this is called the cephalomedullary nail. That means the nail is in the medulla and the screws are in the head. Yesterday we have dealt with one more nail, that is for tibia, that is called intramedullary interlocking nail. So in that the screws are present above and below, locking the fragment. Here it is in the head of the femur. So this is called a cephalomedullary nail, which is called as the proximal femoral nail, PFN, for treatment of your IT fractures. There are other treatments also for IT fractures, which is called as DHS. This is the dynamic hip screw. This is the dynamic hip screw. Right? So dynamic hip screw is nothing but, again you will see there is a plate and then there is a screw in the head. Right? So whenever there is a screw in the head, it is for the IT fractures. So this is plate and a screw. This is a nail and a screw. So DHS is a plate and a screw, and this is a nail and a screw. So these are two important treatment modalities for your IT fractures. Okay. And complications we have already dealt. So one is non-union, the second one is the malunion. So whenever there is a non-union, again you have to treat that non-union, right? So this treatment of the non-union can be done with the bone grafting, right? So there are various bone grafting pedicles. So one such is the Mayer's pedicle. So Mayer's pedicle. So here what we do is we take a muscle which is very rich in vascular supply, which is called as the quadratus femoris. Quadratus femoris is a quadrilateral shape muscle in the hip region, and this quadratus femoris we take it and we put as a bone muscle pedicle graft for non-union. Usually we don't do it, is in the theory which is given there. So that is non-union is treated with this that is the muscle pedicle graft. So bone muscle pedicle graft. Okay. Done. So this is the Mayer's procedure. You have to remember one point. The second point, the treatment of non-union. So one is grafting. The second one is osteotomy. So there are multiple osteotomies which we can do for treatment of the non-unions, right? Otherwise, again, we completely remove the head and we again put the prosthesis. Okay. So these are the treatments for the non-union of the femoral neck. Okay. The second topic is the posterior dislocation. Any doubts? Any doubts in IC and IT fractures? So the important part here is the treatment, which depends upon the age group. Okay. What advice you give after THR? You mean what advice we give? Nothing we give. We mobilize them properly and they can happily roam. They can walk. It's a regular advice only. We have to do the regular physiotherapy. We have to mobilize the patient and they can actively lead their life. Okay. So now going to the posterior dislocation of the hip. Okay, see, hemiarthroplasty or THR, the decision depends upon the patient and the surgeon. So the patient has to have acetabulum changes, especially the acetabulum changes has to be there. That is the degenerative changes. The acetabulum should have some osteophyte, some sclerosis. So it is an indication that it is also going into arthritis, right? So then only we will change the acetabulum. Otherwise, simply we will not change the acetabulum. The only indication is acetabular changes. That's it. Why did I tell 75 years? Because 75 years patient, whenever you take the x-ray of 75 to 80 years, usually these changes are present, right? That is why. Nishu, actually assuming that as atrioventricular node is also huge for your level, okay? I don't know how are you just sitting and listening to this class. Okay, now let's complete this topic. Okay, posterior dislocation of the hip. This is again another very, very important topic. I have told you it is important throughout your prof, viva, practicals, your NEET PG, INICT, whatever exam you write, the posterior dislocation of the hip is very, very important. So what you would write, so this is a dislocation. So now we have understood what is a dislocation. So the articular surface are not in contact. So what are those two articular surface? So one is your femoral head, the second one is your acetabulum. So the second one is your acetabulum, right? So these two are not in contact. So where they have gone, the femoral head has moved posteriorly. So why it has moved? The most important cause of this is trauma. So this is a very, very stable joint, but still it has moved posteriorly. That means this is always a high velocity injury. So this is always a high velocity injury. And one such thing which you can remember is the triad which is called as the dashboard injuries. What do you mean by a dashboard injury? That means whenever you're sitting in the car, you see the dashboard is on the passenger side where you sit with your hip in 90 degrees flexion and knee in 90 degrees flexion. So you sit like this, right, in the dashboard, and here you have the dashboard here. And whenever there is a accident which is happening and here you go and hit the dashboard, so here the hip is in flexion, right? This flexion and this is in flexion, so there is high chance of this femoral head moving posteriorly. Hence this is called as a dashboard injury, where you will have posterior hip dislocation, right, and a direct hit to patella, so there would be a patella fracture, and then there is an PCL injury. So this is a triad which can happen in the knee and the hip together. This is called as dashboard injury complex. So posterior hip dislocations, patella fractures, and the PCL injuries. So this is the dashboard injuries which can occur in case of your trauma in a high velocity injury. And once when we come to the your ER, the most important in the posterior hip dislocation is the attitude of the limb. So there in the fracture neck, the attitude was external rotation and shortening, right? Here the attitude is flexion, adduction, and internal rotation. So flexion, adduction, and internal rotation. So this is the attitude of the limb. Very, very clear. So whenever there is father, so this is called as father. So father is flexion, adduction, and internal rotation. You will see that the PCL is posterior cruciate ligament. Samantha, you're from which prof? So this is the father. So attitude of the limb is very, very important. So once you see the limb, you can diagnose that this could be a posterior hip dislocation even without seeing the x-ray. That far from as the patient, the stretcher enters the casualty itself, you can tell that this could be this injury just basing on this attitude. Okay, and now then you order for the x-ray, right? You immediately order for the x-ray, and you have to see for other injuries, because I've told you it is a high velocity injury, right? So you have to always look for other injuries as well. Okay, third is fine. And now this is the x-ray. So whenever you get the x-ray, you have to order for pelvis with both hips. This is a single hip, but you have to always order with pelvis with both hips, right? Both hips, I meant. So here what you see, the most important thing is head is posterior and it is smaller in size. It is smaller in size, right, compared to the opposite side. And then you see that the Shenton's arc is broken. So what is a Shenton's arc? It is nothing but a line, right? So this line, whenever it is through the this particular line, so this Shenton's line is broken, right? So it is not there in continuous. So this is the superior inferior part of superior pubic rami, this particular area, and now the medial part. So this is not continuous. So there's a break in the Shenton's arc. So there is a break in the sentence arc. And then what you can see, the LT, the lesser trochanter, is not seen. That means the limb is in internal rotation. So this is the lesser trochanter. We have seen there, this is the greater and this is the lesser. So here you can't see the lesser trochanter. So whenever you see an X-ray, you can always see a lesser trochanter, right? So this is a greater trochanter, this is like a lesser trochanter. So whenever the limb is rotated, the LT cannot be seen. So this is limb in internal rotation. So the limb is in internal rotation, right? So these are certain X-ray things which you can identify. So once you see this particular X-ray and you see on the clinical examination, the head is present in the posterior part. So head is present in the posterior area. So then you confirm this as posterior hip dislocation. Yes, proximal migration, that is the shortening. Shortening is also seen. Yes, shortening is also seen. Shenton's arc is nothing but it is a line which is drawn on the X-ray. So what they do is, this is the line. So whenever you take, I'll show it in the normal one. So this is the Shenton's arc. So if you take this line over the superior pubic rami, inferior part of the superior pubic rami, along the medial aspect of the femur, you will find this arc. So this is all continuous. But whenever there is a fracture, or if you see, this is the medial, right? So this is break in the Shenton's arc. So this part. So the inferior part of the superior pubic rami and the medial femoral neck is in line. So they form an arc. So this is the Shenton's arc. So here you can't see the Shenton's arc, right? So Shenton's arc, if you see, this is the this is the part of the superior pubic rami, inferior part, and this is the medial part of the neck. So this Shenton's, there is a break in the Shenton's arc. So that is the Shenton's arc. Okay. And now any fracture dislocation, any dislocation should be immediately reduced. So it is an emergency. So it is an emergency, right? So in the emergency, what we do, we will reduce the joint. Any joint should first undergo reduction. So how you do? Because this is hip joint is a big joint, right? So first you give anesthesia, right? So you give anesthesia and now you do the maneuver. The maneuver is, first your assistant is stabilizing the pelvis. So this fellow is the assistant, right? And here this is the surgeon. So what the surgeon do? The surgeon will flex the knee. So knee in 90 degrees of flexion and hip in 90 degrees of flexion. So this in 90 degrees, this in 90 degrees. And then what they do? They give longitudinal traction. So again, disengaging the fragment. So first you would disengage. So whenever you're disengaging, you will always exaggerate the mechanism of the injury. That means you will do adduction and internal rotation, right? So you will longitudinal traction in adduction and internal rotation only. So once it is reduced, then you do abduction and external rotation, and you can hear that clunk sound. Okay, clear? So nothing, first the patient is sleeping on the floor, then this assistant will stabilize the pelvis, right? And then you will hold this knee in 90 degrees of flexion, hip in 90 degrees, and then we give the longitudinal traction. So the traction is given upwards like that, longitudinal traction. But when you are giving the traction, you will not move the limb here or there. You put in adduction and internal rotation only, and you give the longitudinal traction. And then what you do, slowly you abduct and external rotate. So whenever you're doing this abduct and external rotation, you can hear a clunk sound, so that the hip is reduced. Then you take an X-ray, check X-ray, CM, then you will confirm the reduction. So once it is reduced, again you have to immobilize. You have to immobilize in skeletal traction. So you are going to immobilize in the skeletal traction for 3 weeks. So before that, you will check for the stability. So always you have to check for the stability. So even though once it is reduced, there are high chances that again it might dislocate. So you will check for the stability and then you will immobilize in skeletal traction for 3 weeks, right? So most important thing here again is the complications, right? So what are the complications? So first one is the sciatic nerve injury, which we can expect, right? That is very, very important, right? The sciatic nerve injury can happen. there is a high risk of avascular necrosis because it is going posteriorly. The blood supply might disrupt, so it will land up in AVN. The late complication, it might land up in myositis ossificans. And what is myositis ossificans? We'll discuss it later. And finally, your osteoarthritis, the secondary osteoarthritis. So these are the complications which we might encounter in case of your posterior hip dislocation. Fine. So what is myositis ossificans? The name suggests myositis. Myo means muscle. Ossificans means the muscle is forming into bone. So that usually happens in the elbow and the hip joint. So this is one of the complications which might occur in case of your posterior hip dislocation. Fine. So this actually I wanted to teach you about the growth factors, but it is not included in the syllabus. So I have not. The answer is BMP 2 and 7. Okay. The procedure is very simple. Nothing, don't make it complex. Just be clear. First, longitudinal traction. So before giving traction, you have to stabilize the pelvis. The knee and the hip is stabilized here. And now what you do, you give traction upward. So while giving the traction, you don't move the limb here or there. You put it in adduction and internal rotation position only and give traction. So once after giving the traction, you will feel that something is released, and then you do abduction and external rotation so that it will fall into its place. Okay. Myositis ossificans is nothing but it is a condition or complication where the muscle is converted to bone. Okay, the muscle ossifies to bone. So there are certain muscles, example in the elbow joint, it is the brachialis muscle which comes into bone. And in the hip also there is muscle, some amount of muscle is converted into the hip. But this is seen in the joint. So whenever there is ossification in the joint, no, there will be restriction to the movement of the hip joint. So that is why we have to be careful with the myositis ossificans. So this is one of the complications which might be seen in your posterior hip dislocation. Yes, sciatic nerve is the one which is present on the posterior side of the hip joint. So once the head goes into the posterior aspect, it might damage the sciatic nerve. And this is supposed to be the most important, which is thickest nerve and the longest nerve of the body. It transfers from the hip joint to the ankle, right? So that's it for the trauma, the Farre. So you have to download it from the Medad app and explore the Farre. This Farre series is for all the subjects. So everybody is teaching really good, and you can have the access for all the Farre subjects. Okay. So this is mainly for the prof exams, right? Your university exams where you can score good marks even in the exams, the theory exams. Hope everything is clear. Any doubts? Any doubts? I will come. On Jan 3rd, we have class again. Patients cannot flex the hip joint also. We usually, that is why we do immobilization, right? We do immobilization for 3 weeks. See, anything is never enough for any exam. MBBS is like an ocean, okay? We have to just keep reading, just keep exploring, that's it. Nothing is enough. Okay, then see you all. Thank you so much. Samantha, what do you want? Colles cast. Colles cast is again the same thing. You give traction. I've told you. So this is the I assume that there is a fracture here in the wrist. Okay. Now the surgeon will hold and they will give traction like this. So if you're pulling like this, no, the elbow completely comes. So somebody has to give a counter traction, right? And once you give this traction and counter traction, and the surgeon presses the dorsal part, the dorsal displacement, right? So you will press the thumb over the dorsal part and put it in palmar flexion and ulnar deviation like this. So this is palmar flexion and this is ulnar deviation. So once you do this, the fracture fragment sits inside, okay, with the bone. Okay, then you put the cast. Oh, yeah, Mahesh, I've been to temple in the morning. Vaikunta Ekadasi Subhakangshalu. Happy New Year. Yes, Happy New Year to all. Enjoy your New Year. Okay, now any doubts? I forgot to tell you. So I am available at Dr. Alekhya Ortho on Insta. So please put all your doubts there. I will clear it. Okay. Thank you so much. Happy New Year to you all. Bye. See you all on the next class. It is on Jan 3rd. Okay. See you. Bye.